Great. Thank you very much for the opportunity to speak to you today. So as mentioned, I'm an adult hematologist-oncologist based in Boston. I'm at Dana-Farber. And I'll mention to this group that over the last 2.5 years or so, we've really developed a unique multidisciplinary program in Boston. This is in partnership with people like myself at Dana-Farber, as well as people that probably are well known to this group, Dr. Agarwal and Dr. Benjamin Reilly as well, that helped care for patients across the age spectrum with telomere biology disorders. And I wanted to get a sense from the group, how many of you have actually heard a talk before about adult complications in TBD patients? It doesn't appear to come up very often, right? And so this is something that I've found in my practice as well, is that often, even in patients or in families that have been diagnosed with telomere biology disorders, they often have limited understanding of how blood disorders develop and how we can best monitor them. And so that's really what I wanted to focus this talk on today. And I have 10 slides, and the purpose of this is really to go over key concepts that I think about on a daily basis and how I would like to impart this to you all and hope to inform some of the questions that you may have come here with. And so this is the outline of the talk, so I'll start by just giving a brief overview of normal blood production. We also refer to this as hematopoiesis. I'll explain a little bit about how telomere maintenance occurs and the function of that process in normal blood cells. And then I really think about the hematologic complications in adult patients along a spectrum. And I'll explain this from the point of view of what is going on at the stem cell level. And then I'll share with you my personal approach to hematologic surveillance for our adult population, recognizing that we are still in the process of gathering a lot of the data needed to best understand how optimally to monitor our patients. And then I couldn't help myself but share a story in which we have started to realize just how unrecognized adult patients with telomere biology disorders are and how we're trying to address that systematically at Dana-Farber. So I'm sure many of you in this audience have seen a slide like this before, and this is just depicting how normal blood production occurs in the body. And so everything really starts at the level of the stem cell. We refer to this as hematopoietic stem cell, blood stem cell, and this is a very small population that we're born with, say, 100,000 of these, and they are responsible for producing the trillions and trillions of cells that keep us alive, that give us oxygen, that help us to fight infections, produce antibodies, and immunity against all kinds of pathogens. And so there are really two branches on this tree, and so I'll really focus most of the talk today on this myeloid branch. And this is a population of cells that eventually in the bone marrow produces the cells that are in the circulation, the healthy red blood cells, the platelets that help prevent bleeding and help the blood to clot, and the white blood cells, or at least a subset of them, that help us fight infection. And I'll also highlight here at the top that this is really important, is that the body has a certain demand every day of a certain number of blood cells. And this system is highly regulated, it's orchestrated in such a way that the supply is able to meet demand. And when this really highly regulated system is perturbed in some way, which it often is in patients with telomere biology disorders, the supply doesn't meet the demand, and some form of hematologic complication ensues. And so I wanted to share just exactly how we think about telomere length in blood cells. And so this is an interesting study that was done a few years ago where they looked at patients of various ages from birth all the way until age 70 and beyond, and looked at telomere length in different tissues of the body. And it had been assumed for many years that telomere length across all tissues decreases steadily throughout life. It turns out that's true, but this was really one of the first direct evidences that told us that. And so what I'm showing you here is telomere length right here, and the age of the individual. And you can see here that blood telomere length, highlighted in pink, is the shortest of all the organ system, at least that was surveyed here. And you can see that across the age spectrum, telomere length in the blood steadily declines. And this makes sense as we think about the stem cell dividing to produce all the healthy blood cells that we need. Now, how is this different in patients with telomere biology disorders? And so this is a wonderful study published by many, including Dr. Savage in the background here, in which they looked at telomere length not only in healthy adults, but also in patients with telomere biology disorder. And so what I'm showing you here is telomere length again relative to the age of an individual. And you can see that patients with telomere biology disorders, highlighted with these black circles, really have critically short telomeres in their hematopoietic stem cells and the cells that are derived from those stem cells. Now, why is that important? And this is, I think, where a lot of people get lost. And so when the cells in our body, particularly the hematopoietic stem cells, have very short telomeres, it sends a powerful signal to the cell to stop dividing. And when that happens over the course of thousands and thousands of our stem cells, eventually the supply of our blood cannot meet the demand of the body, and we develop blood complications, low blood counts, and then one of the feared complications in patients with telomere biology disorder is blood cancers. And so that's what we'll talk about. And so as I mentioned at the outset, I really think about the hematologic complications in TBD patients along the spectrum. And so on one end of the spectrum, you have patients that have low blood counts, where the supply does not meet the demand, and patients either have low white blood cell counts, they're at risk for certain infections, particularly bacterial infections. They have anemia, low red blood cells, and they also can have low platelets, and some combination of these. And this is just a representative image of what patients' bone marrows can look like when they have a deficiency of hematopoietic stem cell number and function. And we think about the management of this as very much in the way of supporting it. So patients will need blood transfusions. We give a lot of our adult patients red blood cell transfusions, platelet transfusions. We also often consider giving them growth factors in an attempt to stimulate the production in the bone marrow. And then for many of our patients, even adult patients that have severe bone marrow failure, we think about replacing their diseased stem cells with healthy stem cells from a donor in the form of allogeneic stem cell transplant. Now, on the other side of this spectrum are really the feared complications that we all think about, or try not to think about, which is blood cancers. And so the two major forms of blood cancers that I see in my patient population are myelodysplastic syndrome and acute myeloid leukemia. Does anyone in the room have any familiarity with these diseases? Has anyone had a family member, anyone else that has developed MDS or AML, unfortunately? Good. Okay. So I can say that this is the primary type of blood disorder that I see every day. And I wanted to kind of highlight for you how this actually occurs, because I think it's helpful to think about how we can surveil patients. And so all of these conditions really derive from changes, acquired changes in the DNA that are in the hematopoietic stem cells. And over time, that can lead to blood cancers. And this is something that we can readily detect now. And so we have a platform at Dana-Farber where we can look for these changes in these blood cells. And that can often precede the development of blood cancers by several years in many cases. And so one of the things I'd like to highlight is that when patients progress from a state of low blood counts where the supply is not meeting the demand to something like a blood cancer, there's often changes that we can detect in the blood cell. And so one of the key efforts that we have ongoing in our program is to really understand what are the specific changes that lead patients to develop a blood cancer. And I think this is something that would be beneficial to know in the way that we can early detect disease at the earliest possible stage and then potentially intervene when outcomes might be better. And so I wanted to share with you some of the growing data that we have from our program. And so this is just representing over the last 2.5 years a growing number of adult patients with telomere biology disorders that we care for. And so this is representing largely adult patients that were diagnosed in adulthood. So these are patients that come to our clinic through genetic testing for other means. So they had a family history of breast cancer, colon cancer, and they inadvertently were found to have a gene related to telomere maintenance and found to have a telomere biology disorder. I have some patients as well that were diagnosed as kids, as children, and eventually need to have adult care as well. But it's a wide spectrum of ages, as you can see, a wide spectrum of clinical phenotypes, and many different germline causes as well. And this is the same cohort that is part of our larger pediatric adult integrated program that includes pediatric patients cared for by Dr. Agarwal and shared care with Dr. Reilly as well. And as I was mentioning, these key changes in the blood cells that develop as a precursor to developing a blood cancer are readily detectable. And so one of the key things that I have incorporated into my hematologic surveillance is making sure that we do blood DNA sequencing on all of our patients. And this has been really game-changing when we start to look at the data that we have, particularly on our adult patients. And so we know that as a normal consequence of aging, all of our blood cells develop changes, mutations in our blood cells. But what we know is that patients that have a telomere biology disorder, shown here in green on this graph, have a really, really high incidence of having these acquired changes. And we also are starting to see that there are specific patterns of these changes that can help us better predict who's at highest risk for developing blood cancer. And so this is ongoing data that we're developing here, and we have some active research projects on the pipeline to really help us understand this question. So I wanted to take a second and explain exactly how do we use this information? How can we use the composite information of blood counts, of bone marrow biopsy, as well as the next generation sequencing, the DNA sequencing, that can help us risk stratify our patients? And so at a baseline, what we do is we always check for new patients their blood counts. I do a somatic or NGS mutation panel to understand if those changes are present, and then also a diagnostic bone marrow biopsy. And what exactly are we looking for? So I think Dr. Olson spoke to this as well. We're looking for things like the cellularity of the bone marrow. We're looking for any signs of abnormal development. The term that we often use to describe that is dysplasia. And we also look to see if there's any abnormal population of blood cells that kind of gives a sense that patients are progressing towards a leukemia. And so I think of patients really into three buckets, at least initially. I think of patients that have a completely normal blood count, meaning that they get their CBC checked, their red cells are not enlarged, all of their blood counts are in the normal ranges. And we do an NGS sequencing panel, and we don't detect, thankfully, any mutations. And so for these patients, in general, what I do is I check their blood counts several times a year, about 4 to 6 months, and then if there's a clinical change in their blood counts or some other indication, that would prompt me to do an additional bone marrow biopsy and molecular assessment. There are other patients that come to me that have severe low blood counts of some variety. And so these patients have low blood counts, and many of them, as I just shared with you, also have acquired changes in their blood stem cells. And these patients I think of as higher risk. Higher risk for what? Developing something like myelodysplastic syndrome or leukemia. And it's for these patients that I escalate the surveillance strategy. And so for these patients, I check their blood counts more frequently. And I also recommend a bone marrow biopsy with a molecular assessment every year. And these are also the patients that I have a very low threshold to refer over to one of our stem cell transplant colleagues to talk about a bone marrow transplant. What I'm finding as well in my clinic is that there's a middle bucket as well. There's patients that have some mild blood count abnormalities, and they may or may not have any detectable mutations. And so for these patients, I really have to do it case by case. I really have to meet patients where they are, understanding how readily they can check their blood counts and understanding, what would be the threshold for which to do something like a bone marrow biopsy or a sequencing panel. And so this is data driven by our program, recognizing that we're still accumulating more data to understand what is the optimal strategy. But this is how we are approaching it. And I'll also mention that patients within any of these buckets can move. It's a moving target. So from one year to the next, patients may develop new blood count abnormalities, and therefore the surveillance strategy has to change accordingly. And one of the other things I'd like to mention to this group is how often we are actually encountering patients that have clinically unrecognized telomere biology disorders. And so we did a study a few years ago where we took kind of a different approach. We said if we looked at all patients with blood cancers, one particular one, so if we looked at all patients with myelodysplastic syndrome and asked the question, what proportion of these patients have a clinically unrecognized telomere biology disorder? And so to assess this, we sequenced the TERT coding region, and we found that there are germline inherited variants in the TERT gene in approximately 3% of adult patients with myelodysplastic syndrome. And all of these patients did not have a known diagnosis of a telomere biology disorder. So these were clinically unrecognized. And what we found is that these patients had shorter telomere length, and they were also diagnosed at a younger age with MDS. But there was a wide range of ages between 14 and 72, but most of these were adult patients. And what we found is that if you had a TERT variant and you underwent an allogeneic stem cell transplant, patients actually did a little bit worse than those that did not. And we then characterized the function of these variants and identified that most of these, in fact, are pathogenic. They have an impaired ability to extend telomeres. And so this really gave us the first inkling that we are actually missing a lot of these patients clinically. We don't actually understand the true prevalence of these. And so what this information has allowed us to do at Dana-Farber is we've now systematically, for every patient that has a question of a blood disorder, they're all screened for gene variants in telomere maintenance genes. And this has allowed us to really capture many, many more patients that are at risk for blood cancers that would otherwise go undetected. And so this is another key aspect of our work in our program. And so in conclusion, what I'll leave you with is that telomere maintenance is essential for normal blood production. Adult patients are predisposed to a spectrum of conditions, both bone marrow failure as well as myeloid malignancies, MDS and AML. And that really I'd like to emphasize for this group is that blood DNA sequencing is a really helpful tool in understanding what are the changes that are developing in our patients that are most worrisome and how we can best act on them. And then lastly, also that the systematic approach to screening patients is really helpful in identifying all those that may have a clinically unrecognized TBD. And so I wanted to leave plenty of time for questions. I know this is a topic that can create some anxiety and fear in the audience. I just wanted to give plenty of opportunity to answer any questions that you came here with.